Hi, welcome to The Vitals, Mount Sinai Health System's newest video podcast. I'm Leslie Schlachter, and I'm a neurosurgery physician assistant. I'm really excited to have Dr. Elisa Port with us today. She is chief of breast surgery here at Mount Sinai Hospital. She specializes in treating patients with breast cancer or those at high risk of developing breast cancer. The reason we're going to talk to her today is to specifically talk about the new Surgeon General's warning, which says that alcohol gives you an increased risk of developing cancer, and breast cancer is one of those. So we're going to talk about how alcohol increases that risk, signs and symptoms of what to look for, and what the treatment looks like. We're really excited to have Dr. Port today. Thank you so much for being here today.
Thank you for having me, as always.
I was looking forward to spending time with you.
Oh, yeah.
Great.
Yeah.
Before we get started,
Strumming out of the podcast.
for sure. Before we get started, I had my mammogram last year, and it's perfect.
Good.
My pec muscles have gotten even bigger from all my hard work.
All your hard work has paid off. My congratulations.
So, okay, we're here to talk today about the Surgeon General's new advisory on alcohol and its relationship. Tell us what you see as far as trends with breast cancer and how you think that could be related to alcohol. Like, have you seen it on the rise? Do you think it's related? Tell me what you think.
We have known for a very long time that there is a relationship between alcohol and some kinds of cancers. Some are obvious and some are not so obvious. I would say, of course, there's an increased risk of cancer that someone could say makes total sense between alcohol and like esophageal cancer, right? Stomach cancer, because those are toxins that are directly in receipt of the alcohol, right? You drink alcohol, it goes down your esophagus to your stomach, and that exposure can be toxic, right? What people didn't understand is what the relationship is between some of these other kinds of cancers, like alcohol theoretically never really sees your breast tissue, or does it, right? And so how would alcohol increase your risk of breast cancer? We did know that there are two dietary factors that do increase your risk of breast cancer. We've known for a long time. Obesity and heavy alcohol intake. And what had not really been clarified is how much is a lot, how much is heavy, how do you define moderation and all those things. It's sort of like a sliding scale.
Especially for men and women, because women is like, I think excluding me because of my size, but less alcohol. It's not that much that you're allowed to drink.
And right. And how is, we all define one drink as the same amount, right? Like one, I don't know, I think it's 6 ounces, right, of wine, one shot, whatever. But you're right. Why is that the same for a 100-pound woman versus a 200-pound man? Why is that the same?
Right.
And you're right. The answer is it's not, right? So the relationship between alcohol and breast cancer is definitely one of the things that's been really recently clarified, is that we used to say heavy is worse than moderate. You know that, okay? Which is worse than a little. And we kind of lumped a little and none together. That having a drink or two a week, or even up to 3 drinks a week, which we would consider a little, is not really any increased risk. Now, with the new data has shown that really there's unfortunately no amount of alcohol that is associated with no added risk. Now, let's get into the weeds with this for a minute, because how much is increased risk? If the average woman's risk of getting breast cancer is 10% over her lifetime, and we say, 1 to 3 drinks a week increases your risk by, say, 10%, and I'm making this up. Everyone says, oh my God, now my risk is 20%, right? 10%. It's not like that at all.
Right.
It's 10% of your original number, 10%. So now your risk goes from 10% to 11%, because 1% is 10% of the 10%. Right. So that's how you do the math. So, the press and the media play a lot of fast and loose with these numbers. Like, it increases your risk by 10%, and people go nuts over that. But you have to remember that the added risk is really marginal. Okay.
So I have a question for you. I did a little bit of research to get ready for you today. We know there's several different mechanisms of how alcohol increases your risk of cancer. One of them specifically is that alcohol alters hormone levels, specifically estrogen, which really only calls out breast cancer here. So the one thing that I don't know much about breast cancer other than I know how to get my mammograms every year, but I've heard of like the BRCA gene, all of these like estrogens and genes. Now, how does this play? Like, are people going to be just as worried about alcohol as they were about the BRCA or the genes?
The genetic predisposition is very different. When you're born with the BRCA genes, your risk of getting breast cancer for your lifetime is 60 to 90%. That works by a completely different mechanism. Let's go back to what you brought up, which was absolutely true. So we started talking about how, esophageal cancer and stomach cancer would be obvious connectors to alcohol because it's the exposure directly, right? And we said, but that doesn't really work for the breast. So how does that work, right? What's the mechanistic connection? And the answer is you're right, through hormones. So one of the things we know is that hormones are broken down by the liver. They're metabolized by the liver. What else is metabolized by the liver? Alcohol.
Right.
So one of the big kind of theories is that if the liver's so busy over here metabolizing the alcohol, it won't do a good job over here on the hormones, and you'll have increased circulating hormone levels because they're not.
So it's almost like a receptor blocker.
It's not like a receptor blocker. It's almost like a competitor.
Okay.
In that the alcohol is kind of throwing a diversion. So you end up with higher circulating estrogen levels. And you're right, Leslie. So the bottom line is of all breast cancers diagnosed, and it is the most common cancer women get in this country. There's about 300,000 new cases diagnosed every year. Okay. About 60 or 70% of them will be what's called hormonally driven or fueled.
Okay.
So it's very relevant, these estrogen levels. And it's for the same reason why hormone replacement therapy probably increases your risk of breast cancer, again, by a little bit.
Right.
It's the reason why, birth control pills over a long period of time can increase it's all the end thing is, what is your exposure to estrogen in your bloodstream, and what's your breast cell exposure to estrogen? So somehow if alcohol is modulating your exposure, the estrogen level circulating in your body, that's probably
It makes total sense.
Yeah.
So one of the things about diagnosing breast cancer that's actually great for women is that there's guidelines, right? There's guidelines for when someone with no family history or genetic predisposition, she had a mammogram.
The general pop.
Right. Can you discuss what that is?
Sure. The general population guidelines.
Both of them, risk and gen pop.
Yeah. So obviously, as you mentioned, the spectrum of risk is a range. So let's talk first about the average woman whose risk is about 10%. That's a woman with no other risk factors, no family history. The big risk factors are family history and having a prior biopsy that shows some borderline findings. So if a woman doesn't have that, and remember, there are other risk factors that can dial up the risk a little bit, like
right.
If you had children late in life or if you've had no children, that increases your risk a little bit. Okay, but if you're in the average risk group, the guidelines are to start getting mammograms at age 40, okay? And every year, as long as you're healthy enough to have them and deal with the consequences. So we no longer say stop at age 70 or 75 because women are living a heck of a lot.
Yeah, you have like a 75-year-old woman who's playing pickleball every day.
That's
doing great.
Yeah. Okay. You can get your mammogram. Absolutely. So those are the guidelines. Now, the addition of sonograms on top of that need to be considered in women with dense breasts. And that's a lot of women in the 40 to 50-year-old.
How do you know if you have dense breasts?
The mammogram will tell you.
Okay.
It's not something you can feel. Even women who say, I feel like my breasts are lumpy and bumpy, that's not an indicator.
Lumpy is normal.
Lumpy bumpy is normal, especially for young women. I say everyone's breasts are like a cobblestone street for them. What you're looking for is one standout, like the boulder, which we call a dominant finding or a dominant mass. That's what you need to pay attention to. But you add on ultrasounds, based on breast density. And breast density can only be guided by the mammogram. Okay. And that's a scale at a range. And, and what happens is that the density is dictated by the amount of what we call functioning tissue that you have there. Breasts are composed, the makeup of the breasts are composed of two types of tissue, and we all have both. There's fatty tissue and there's functioning tissue. What's the function of the breast? It's only one thing: make milk for babies, right? Yep. Lots of people think there are other functions, and that's fine too, but that's the main way. Yeah, making milk for babies. And the way milk is made in what's called lobules, and then that milk is delivered through like a pipe system.
Is that where cancer comes from, in those areas?
Hang on. It's delivered along the pipes, which are called the ducts. Right. The ducts and the lobules are the functioning tissue, okay? Cancer can start anywhere along the duct system or in the lobules. It can start anywhere.
Called like ductal carcinoma.
Exactly. Okay. Duct carcinoma or invasive ductal cancer or lobular carcinoma. So it can start anywhere there, okay? The amount of functioning tissue to fatty tissue is what dictates breast density. I see. So think about it. If you're young, if you're 20, you're 30, you're 40, you're in the childbearing age, your body's all, ready to have a baby and ready to put those cells to work. That's when you're going to have breast density, right? Now, when it becomes trickier is what happens when you're 50 and 60, but your breasts are still dense, right? So those are things where there might be a higher risk of breast cancer, and it might be harder to detect a cancer on mammogram. The reason I brought up the density thing is density on a mammogram shows up as white, okay? The fatty tissue shows up as black. Cancer is white.
It blocks you.
So what it is, it's like the polar bear in the snowstorm. Wow. The whiter the tissue is, as it relates to the amount of density, the harder it is to see a new cancer against that background. Okay.
That makes sense.
And that's why if someone has a mammogram and their breasts are very dense, we say, gosh, are we really sure that there's not something hidden in between here? Maybe we should do another test that looks at things differently. And that's when we often add on ultrasounds.
Do you think that now the layman, I mean, you just said you've known this for years, that alcohol can predispose or increase your risk of getting cancer. Is that going to change the guidelines? Like someone who drinks more than 10 drinks a week should get mammograms at 30.
You know what? It's such a great question and so insightful. My sense is no, because, for example, like the other risk factors I talked about before, we don't change the guidelines if somebody like
on birth control.
Exactly, right. Or on hormone replacement therapy. I can tell you on a case-by-case basis, sometimes GYNs or primary care doctors have those conversations with their patients and say, you might want to consider getting an ultrasound, or you might want to consider, some more high-risk surveillance. We were talking about the spectrum, and on the opposite end of the spectrum, the people at the highest risk for breast cancer, which you had mentioned.
Right.
Mammograms and even sonograms are not enough. We also screen those people at what age with MRI. So the guidelines for them, because women with BRCA not only get breast cancer at increasing rates, they get it younger.
Okay.
The average age that a woman is diagnosed with breast cancer in this country, non-BRCA, is about 60.
Okay.
With BRCA, women can get it in their 20s, 30s, and 40s.
And they would know that from a mother and a sister.
They might, or on the father's side of the family. BRCA can be passed down through both sides. So not everybody knows that they're carrying these genes. And that's why we're very big advocates for more widespread testing, because you could be identified as a person who's at increased risk and would benefit from not only more screening, but starting that earlier. So you asked, when do you do the screening?
So that's scary. You're not getting your mammograms, but you're at increased risk of a more aggressive. What do they look for?
So the regimen for screening with BRCA is you start MRIs every year starting at 25.
Wow.
And then you add mammograms at 30. And you do that, mammograms and MRIs.
Every 6 months or something, and you're staggering.
Yep. Yeah, and you do that every year until, if and when, God forbid, someone develops breast cancer, or they decide to do surgery, what we call risk-reducing surgery, to really reduce that risk.
Like what people used to call like a prophylactic mastectomy.
We now call it more appropriately risk-reducing, because you don't completely prevent it, but you do reduce the risk down to about 1%.
So where could it come from if you're doing a mastectomy, if you're removing a tissue?
You leave about 1% of breast cells and tissue behind, usually on this.
It's like the stuff you can't really see.
You can't see, you can't feel, and there's just a thin layer of tissue. But if you've done the operation properly, the risk should be about 1%.
Thinking about your patient population, those who are in that high risk area, what percentage of your patients would choose for a risk reduction procedure?
Well, remember one thing. That's not a question I can answer because I'm a surgeon.
Oh, that's true. You're only seeing the ones that want it. Yeah.
Or the ones who. Now, I see a lot of patients, to your point. It's so funny you bring this up because literally the conversation I had with my team before I walked over here was a young woman who I had seen 5 years ago with the gene. I had the whole conversation with her about the options. You can do the surgery, you can do the screening. If you do the screening, we have a high-risk program at the Dubin Breast Center throughout Mount Sinai where people can be monitored. You don't need a surgeon if you're just being monitored. So she has been monitored in our high-risk program for 5 years. And I was looking at my schedule next week. I'm like, I remember that girl. What's she doing? Right. My nurse says she wants now, it's 5 years later, she's ready to have the surgery. So the point is that not everyone that comes through my office is ready. Most are. Right. And some just want to have, I call it the talk. And we have the talk. And if they're ready to schedule surgery, it's not only yes or no, but if so, when. Some will turn around and say, I want to do it, but I think I want to breastfeed a child first. So I think I'm going to have my kids and then I'll come back. I'll circle back to see you. Some women turn around and say, I don't want to go through a pregnancy with the gene. You can't get screened effectively during pregnancy. And so they feel very nervous that they're,
But doesn't going through a pregnancy sometimes reduce your risk?
Not in the BRCA.
Okay. So that's separate.
What I would say is it's to your point where we started talking about risk. Here's the regular woman and here's BRCA. When your risk of getting breast cancer is 90%, do you care if you dial it up 1% or dial it down 2%? The in-between stuff are the things like this stuff like the alcohol, the hormone.
Yeah, so this is the alcohol drinking group.
And it's not a drinking is over here. It's closer to here. Right. And remember one thing is that, the alcohol thing, like having, 1 to 3 drinks a week and keeping it that, which we would define, moderation had been defined as 3 to 5 a week. Right. And one of the reasons that we define it that way is that means that you're definitely not having a drink every day. If you're only having 5 drinks a week, there's no way you can make that every day. Right. But it gives people a little wiggle room where if they go out on a Saturday night and they want to have a cocktail and a glass of wine, that's 2. And maybe they can have 1 or 2 more drinks a week. Okay. That is still worse, we know, from a breast cancer standpoint than none. But the thing is, there's lots of things like that. People accept added risk all the time. Great. With things like, again, birth control pills, hormone replacement, for quality of life, for decisions, for all of those things.
You have a daughter.
I do.
She's in medical school.
She is. I texted her before to see if she was studying it here because she's such a tool. She just works her brains out. So I said, are you over here? Could I come by? And she goes, no, I'm sitting in my room today. Too many people in the library. I'm like, okay.
For her.
Yeah.
Let's say next time you guys are out having dinner and she said, Mom, what do I do about alcohol? What's your advice to her?
Yeah, I really say, I really say that, in moderation is really that's the rule I observe too. Yeah. We have people over for dinner. I'm opening up a bottle of wine. Okay. That bottle is not just going to be for me. Right. It's going to be shared. But I feel like it is, an important part of quality of life for the people who want it. Now, could I go 2 or 3 weeks without having any? Of course I can. And for people who've made that decision, and remember other things, and that is that it's also, alcohol is also wrapped up in other things, Leslie.
Oh, yeah.
Weight, Okay. So, what people,
Sugar content.
yeah, exactly, sugar content. So people who are interested in weight loss, who find themselves drinking 3 to 5 a week, that's one really easy way to cut calories, right? Each drink is probably 200 or 300 calories. So now you're talking about eliminating, if you're drinking 5 a week, probably 1,500 calories a week.
It's a lot.
It's a lot. And there are other things too. People talk about side effects related to, alcohol. People get headaches, they get hungover even after 2 drinks, things like that. These are all things that are part of personal decision making. I really think that in moderation, which is up to 5 drinks a week, is a personal choice that people make. When someone comes in to see me and I see that they're drinking upwards of 5 drinks a week, so even 7, when someone says, and remember,
You have to like double what they say sometimes.
that's true. But the other thing too, you're right. And the thing is when someone says, I don't really drink that much, I have a glass of wine a night. It doesn't seem that much, but now you're talking about 7 a week. And to your point, it's not a huge stretch. If someone is having a glass of wine a night, now they're out on a Saturday night, that glass of wine turns into 2 or turns into a cocktail and a glass of wine. Now you're up to 10.
Right.
Okay. And on top of that, it's also what I would say now it's anything you do every day, there's a word for that. It's called a habit. Okay. That's not in moderation anymore. That means you're doing it every night. It's like brushing your teeth, or washing your face. You're doing it every night. That's now a habit. And to me, that's not good when it relates to alcohol. So anytime I see a new patient coming in and they're telling me that they're, having a glass of wine, however they define it, a night, or more than, anything more than 5 a week, we have the talk. And I just say, just be aware. You're an adult, you get to make your own decisions, but just be aware that these are the pluses and the minuses. And I definitely, especially like post-COVID, when a lot of people were drinking a lot.
A lot. Yeah.
We had this talk a lot, I had a woman come in the other day who's like 65 years old, living down in Florida, and she says she has 2 glasses of wine a night with dinner. And when you say it that way, it does not sound like very much. But now we're up to 14 drinks a week.
Right. Okay. Right.
Yeah. Or more, as you said.
Yeah. I'm sure my pour is heavier than like the average pour. Before COVID, like during COVID, I was drinking like a glass of wine a night. But then I actually started to get reflux from it. So I actually kind of stopped drinking. I prefer to have a mocktail or go to the gym or need something. But like, what are we going to replace? Like, hey, do you want to meet for a drink? What are we going to say now? Want to go for a walk?
Cup of coffee, tea, go for a walk. There's a million. By the way, to your point, you can sit at, what you bring up, which is such a good point. People never used to feel comfortable sitting at a bar, sitting at a meal with themselves without a cigarette.
Yeah.
Okay.
They got used to that.
Totally. And, everyone thought that like you sat at a bar with a cigarette, you had a friend, you looked cool, whatever. Thankfully, that has massively gone away for most people. Do you know what it is now? Everyone sits at the table with their iPhone.
Yeah.
They're scrolling, they're reading, they sit with a book. I could go out to dinner any night by myself and with my iPhone and reading and whatever. Everyone feels, you see people now comfortable doing that all the time. So it's just a cultural shift, which is you can sit at a table and have a seltzer water, or like you said, you can have a mocktail, or you can have, you can do whatever you want. You don't have to be out and about and not. And I'd say of my friend group or people that we socialize with, probably about half of them drink, moderately or a little bit or socially, I would say, and half of them don't drink at all.
Yeah.
And it's absolutely it's a non-issue. Yeah. I will say there is a sense that when people are out with other people that they drink and they're in between, they're more likely to go this way toward drinks than not.
Right. Yeah, I'm one of them for sure. So we talked a bit about screening and such, and that's for people who are just like making sure that they don't have cancer. What about people who have symptoms? What are the symptoms of breast cancer? Can we talk about that?
Yeah, you don't listen if that's what happens. So the one thing about mammograms and ultrasounds, right? Mammograms, why do we do them? Mammograms save lives. They do. And the way mammograms save lives is by picking up, they're not a perfect test. They don't pick up all cancers, but they pick up about 85 to 90%.
That's a good test. I'd be happy getting 90% on it.
Very good. It's a very good test. And it's a test that picks up cancers earlier when they're way more treatable and curable. And here's another thing that a lot of people don't know. Not only do they save lives, but a lot of people who get breast cancer are scared of what that treatment might be, right? Nobody wants more aggressive treatment than they have to have. A lot of women are very scared of chemotherapy. It has a lot of side effects. It is hard to go through. A lot of women are scared of getting bigger surgery, a mastectomy instead of a lumpectomy, a smaller surgery, right? Here's a second benefit of mammograms. If you are remember, mammograms don't prevent breast cancer, right?
Right.
If you have a cancer that is picked up on a mammogram or on screening, not only are you way more likely to survive, what I think is equally as important as it relates to quality of life, you're way more likely to survive doing less, way more likely to be able to do a smaller surgery, way more likely to not need chemotherapy, way more likely to not need all your lymph nodes removed because the cancer's spread there. So there's so many other kind of secondary benefits of mammograms that nobody talks about, right? So to your point, if you're not getting mammograms, what's going to happen? How are people going to find their cancers? And only when they're way more advanced. When the lump is not the size of like my baby fingernail, when the lump is like the size of my fist, right? And that's probably 10 times the size. So those cancers, the ones that you feel a lump, that you have nipple discharge, where you see some changes to the skin, where you feel a lump under your arm.
Yeah.
And you get what's called skin dimpling because the cancer is pulling the skin in from the breast tissue. Those are all signs of more advanced cancer that we see a lot in women who don't get screened. And those people are going to almost certainly end up with more extensive, aggressive treatment.
So for people who don't have insurance and aren't getting their yearly mammograms, how much does a mammogram cost if you're just going to pay out of pocket?
So it varies. All insurances cover mammograms, even Medicaid and Medicare, of course, do. Now, they can vary in terms of the age that they start and the age that they stop.
Right.
The cost of a mammogram varies depending on what facility you go to. But really, it shouldn't be more than $10 out of pocket for someone who has some form of coverage.
Okay. So symptoms are indicative of something more aggressive.
Yeah. And look, it's not, again, mammograms aren't perfect. It's not the perfect test.
Yeah.
Can you have a normal mammogram and then 3 months later come in?
Yeah, you can get a cancer in between mammograms.
You can. And yeah, it does happen. The likelihood of that happening is much lower. So it doesn't, put it this way, just because a test isn't perfect shouldn't exonerate someone from throwing the baby out with the bathwater and say, I'm not doing this test because it misses 10 or 15% of cancers. So therefore, I'll ignore the other 85% that it picks up.
So, bottom line, kind of back to the alcohol, we're much more worried about things like BRCA, right? Those are the high percentage likelihood of getting
But as
cancer.
I say, but I wouldn't put it in the same bucket because BRCA is...
So BRCA is over here. I'm putting like estrogen, alcohol, all the other smaller things down here. BRCA is more concerning.
And remember, BRCA is something that you're born with that you can't change, right? You can do stuff about it, like reduce risk by taking out the tissue at risk, but you can't change that you have the BRCA gene. The other things...
Can you develop the BRCA gene? Like if I'm BRCA negative 1 year, can I be BRCA negative in 5 years?
Not. It's something you're born with.
It is what it is.
Passed down. And also it can't skip a generation. So if your grandma had it, but she didn't pass it down to your mother, it can't go from grandma to you. It can either come from your mother or your father. It's very important to pay attention to both sides of the family. And one of the key reasons why people might have the BRCA gene and not know about it, which I always say, pay attention to both sides of your family. Why? What if I had a father and my father just had one brother?
Right.
And I get breast cancer at 35 and I walk into my doctor's office and I say, how did this happen? I have no family history of breast cancer. Well, how can you have a family history when there's no women, right? Breast cancer. So if you are a person, and this could be a very important message, look at both sides of your family. And if there's very few or a paucity of women on either side, you can have a family history.
Send the men for the test.
You could send the men for the test, or you get tested yourself,
Right.
you know?
What if a man is BRCA positive?
Mm-hmm.
Is that a breast cancer? Like, how often do men get breast cancer?
So here's the story. BRCA1 and BRCA2 can be carried by a male, and they both are at increased risk for male breast cancer. With BRCA2, the male's risk, remember, male breast cancer is a really rare disease.
Like, how many men do you treat per year?
Well, in this country, there's 300,000 women who get breast cancer in this country. There's 3,000 men. So it's less than 1% of all cancers in men and less than 1% of all breast cancers. I tend to see a lot of it because we're kind of a go-to center, but it's very rare.
Okay.
So the risk is less than 1% of the average male. But
Men, do they have?
if you have BRCA1,
Do they have lobules?
if you have BRCA1, the risk is 1%, so it's a little bit higher. In BRCA2, it's 7 to 10%.
Wow.
Okay. So if you're a male with BRCA2, your risk is still relatively low, but it's way higher than 10 times. So we are screening some of those men. The key for men, though, Leslie, with BRCA is they're at higher risk for prostate cancer, right? Which is can be a very aggressive form of that. And they're also at higher risk for the thing that both men and women, the kind of cancer that both men and women are at risk for with BRCA, which is pancreatic. So that's a dangerous one. Men can't get ovarian cancer. Women can't get prostate cancer. So they each have that to themselves. But then the pancreatic is shared. Melanoma, skin cancer, is shared. That risk is shared. And the men to a lesser degree, as we said.
What kind of breast cancer is it in men? Because I just went back to my lobule discussion in my head.
It's mostly ductal.
Okay.
In men, it's mostly directly behind the nipple.
Okay.
Male breast cancer can be more advanced at diagnosis because a lot of them are not getting screened.
Yeah, they're not thinking about it.
And also there's like a lack of awareness. I've seen two really smart men, like professional men who go to doctors in the last year. One of them was told the little lump he was feeling was, a skin cyst. And it ended up being, it was blown off for a long period of time. Another man had a nipple change and he was told it was just a rash from his top working out. So there's a lack of awareness on the part of the men and their doctors too, which is a shame.
Yeah.
So by raising awareness, I always say, I don't care if you're a man or a woman, if you've got an abnormality, you need to get it checked out.
Yeah. Well, I'm really happy that you were able to join us today. I actually feel like the other specials kind of scared me. I actually feel a lot better after this discussion regarding alcohol and the breast.
Hear about that? Yeah, it's one of these, what I call, there are things about breast cancer you can't do anything about, like we talked about your genetics, but it is important to know there are modifiable risk factors. And if you're the person who's inclined to do everything you can, it's one of them. It's one more thing on the list that you can do,
Thank you so much for being here. I'm really happy to have you.
Thank you.
Thank you.